Good afternoon, everyone. Today we are going to discuss an important topic on neurology, that is approach to paraplegia. This topic is actually important for bedside teaching. So as we are now not able to continue that bedside teaching, so I'll discuss some of the clinical parts in theory only. So regarding paraplegia, there are few terminology you should know. That is, one is difference between paralysis and plegia. Paralysis means just simple weakness, and plegia is complete weakness. Like that partial weakness or some form of weakness, we can label it as paralysis, and plegia means that complete weakness, complete paralysis. So, by anatomical definitions, it means a loss of voluntary movement due to interruption of one of the motor pathways at any point from the cerebrum to the muscle fiber. So, started with the central nervous system to the spinal cord, even down to the up to muscle. Anywhere if there is interruption to the fibers supplying the muscles, if it is interrupted, then that may result in paralysis or paraparesis. If there is weakness of only of one leg or one arm, that is called monoplegia or monoparesis. If only arm is involved, then it's label it as brachial monoparesis or brachial monoplegia. Or if there is only one leg involved, that is known as crural monoplegia or crural monoparesis. If there is involvement of both arm, leg, and sometimes the face of one side of the body, that is known as hemiplegia. That's what we get in case of stroke. Paraplegia means weakness or paralysis of both legs. And quadriplegia or tetraplegia is weakness or paralysis of all four extremities. Okay. And diplegia, sometimes we use the terminology, the special form of quadriplegia in which legs are affected more than the arm. There is one terminology that is spastic or cerebral diplegia. So there is involvement of all, but that leg involvement is more than the arm involvement. So there is monoplegia, hemiplegia, paraplegia, or quadriplegia. And before going to the subject proper, this is an important question or important concept. We should know the difference between the upper and lower motor neuron paralysis. For any discussion of central nervous system or spinal cord, first thing comes is whether lesion is in the upper motor neuron type or lower motor neuron type. So it's very important to differentiate to know the differentiating point between the upper motor neuron and lower motor neuron lesions. So if you see the atrophy of the muscles, in case of upper motor neuron, hardly we get atrophy. And sometimes you may get atrophy, but that is only because of disuse. Like patient is having paraparesis for almost a year, then because of not using of the part of the limb, there may be sometimes atrophy. But overall atrophy should not be there in upper motor neuron lesions type. But in lower motor neuron lesions, atrophy is very severe. And involvement of the muscles, if you see in case of upper motor neuron type of lesions, there is a group of muscles involved together, never individual muscles. But in case of lower motor neuron type of lesions, individual muscles may be affected. Suppose there is peripheral neuropathy, only one peripheral group of peripheral nerve is involved, and that muscle supplied by that peripheral nerve may be involved. That may cause localized involvement of muscles. But the most important part is the tone. If we see the tone of the muscles, in case of upper motor neuron lesions, you'll get increased tone, that is also known as spasticity. And in case of lower motor neuron lesions, you'll get decreased tone, that is known as flaccidity. And if you look for the tendon reflexes, deep tendon reflexes, in case of upper motor neuron lesions, all the deep tendon reflexes will be exaggerated. But whether in case of lower motor neuron lesions, reflex will be absent. There is an exception in this rule. In case of upper motor neuron lesions, if patient is in the shock, either in the spinal shock or cerebral shock, in that conditions you may have decreased or sometimes absent the reflexes. So in especially in early stage of severe lesion in the spinal cord or cerebrum, there may be sometimes you may have decreased reflexes if patient is in the shock. Fasciculations is a finding of lower motor neuron lesions. If you get fasciculations, then it's likely to be a dealing with lower motor neuron lesions. The dictum is if you are getting fasciculations and together you are getting increased reflexes, that is involvement of both upper and lower motor neuron lesions. So ideally, in case of absent reflexes, deal with fasciculations. Babinski signs, also known as extensor plantar, is the typical or hard sign for upper motor neuron lesions, whether it will be normal or flexor in case of lower motor neuron lesions. In neurology, there are some signs are called hard sign and some signs are called soft sign. Hard sign means if they are present, they are very specific for upper motor neuron lesions. Like Babinski sign is called hard sign. So if Babinski sign is present until and unless he is in the infant less than 12 months of age and sometime in sleep or deep coma. Otherwise, especially if you get unilateral Babinski sign, that is very much specific for upper motor neuron lesions. And lastly, anatomical distributions in case of upper motor neuron is due to pyramidal tract lesions, and in case of lower motor neuron is mostly of the distal or segmental. Okay, so this is how you have to differentiate upper motor neuron lesions and lower motor neuron lesions. Most important is the Babinski sign, then hyperreflexia, spasticity, and in case of lower motor neuron, it's flaccidity, absent reflexes, and fasciculations. Now coming to the today's topic of discussion is the paraplegia. So paraplegia means weakness or paralysis of the both lower limb. Again, the causes of paraplegia, it may be due to upper motor neuron lesions, then it's known as, level it as spastic paraplegia, or if it is lower motor neuron lesions, paraplegia due to lower motor neuron lesions, then it's known as flaccid paraplegia. In spastic paraplegia, again, it can be due to cerebral cause or central cause, and second one may be due to spinal cause. The cerebral causes of paraplegia is commonly asked in the exams. It may be again acute and it may be chronic. The most important amongst all is one is thrombosis of unpaired anterior cerebral artery or bilateral anterior cerebral artery. Second one is superior sagittal sinus thrombosis. Third one is central pontine myelinolysis. And in chronic, in case of cerebral dysplasia, and second one is parasagittal meningoma, and sometimes in hydrocephalus also you may get paraplegia. I'll come to that one by one. Thrombosis and then myelinolysis. First, I'll discuss the causes, then I'll come to its causes separately. Okay, so these are the central causes of paraplegia in acute, and you can divide as acute and chronic. In acute, thrombosis of unpaired anterior cerebral artery, superior sagittal sinus thrombosis, and central pontine myelinolysis, chronic cerebral dysplasia, and parasagittal meningoma. Amongst the spinal cord causes of spastic paraplegia, it may be again compressive or non-compressive. In compressive, again there may be acute or chronic. In acute compressive lesion, most common is the prolapse intervertebral disc. Second one is subdural abscess. Third one is hematomyalgia. And sometimes in case of neoplastic, that is metastatic. In case of chronic, most common in our setup is both spine. Prolapse disc can cause both acute as well as chronic. Different tumor of spinal cord, spondylosis, arachnoiditis. They are the common chronic compressive cause of spastic paraplegia. That non-compressive cause of paraplegia, spastic paraplegia, in acute, it may be mostly the inflammatory myelopathies, that is, it may be demyelinating, it may be infective, it may be immune mediated. And second one is post-infective or vaccination myelitis, and third one is vascular. In case of chronic, it may be upper motor neuron type lesions of motor neuron disease. Motor neuron disease has two components. One is upper motor neuron, one is lower motor neuron. If both are combined, that is known as motor neuron disease. If only upper motor neuron type of lesion is present, that is called as PLS, primary lateral sclerosis. Then multiple sclerosis, subacute combined degenerations like hereditary, brachydactylia, syringomyelia, syphilis, tropical spastic paraplegia, hereditary spastic paraplegia. I'll come to all of this one by one. Okay. First, I just put the note on the causes only. Then coming to the flaccid paralysis, any patient's upper motor neuron lesion in shock stage can cause, looks like flaccid paraplegia. Then in case of lower motor neuron lesion, it may be disease of the anterior horn cells, poliomyelitis, motor neuron disease, or tick paralysis. Peripheral nerve disease, mostly the motor involvement, Guillain-Barré syndrome, lead poisoning, chronic infective demyelinating polyneuropathy, myasthenia gravis, myopathies, or periodic paralysis. But mostly they are of causes of quadriplegia rather than paraplegia. These are all mostly important cause of quadriplegia. Then coming to the how to differentiate compressive versus non-compressive myelopathy, because once you get a patient with myelopathy, first thing you have to rule out the central cerebral causes of myelopathy. Once you rule out cerebral causes, then it comes in the spinal cord. And the spinal cord, the most important is whether it is compressive or non-compressive. As you know that compressive, it means it will involve, suppose there is involvement of the in the suppose lesion in the cervical cord, then it will involve suppose in the right upper limb, then it will go to the right lower limb, then involve the left lower limb, that is then involve the left upper limb. So this is called U-shape. Involvement is U-shape, also known as Ellsberg phenomena. But in case of non-compressive, it's like complete transection of the cord, so it is bilateral symmetrical. Then in case of compressive, you will get typical upper level of sensory loss. You will get the bony tenderness, deformity, then there will be zone of hyperesthesia, root pain, and there will be early bladder wall involvement in case of compressive. In case of non-compressive, it will bilateral symmetrical and will not get all those zone of hyperesthesia, bony tenderness, root pain, and bladder wall involvement normally late in case of non-compressive. These are all except in case of acute transverse myelitis, that non-compressive behaves with like compressive lesions. Like in non-compressive, another important cause is acute transverse myelitis. In case of acute transverse myelitis, you may have manifestation of different like compressive type of lesions. Otherwise, that number one is involvement, like it's like asymmetrical in case of compressive, symmetrical in case of non-compressive, and you'll get all this upper level of sensory loss and the bladder wall involvement. In case of compressive, it will be early, and in case of non-compressive, it is late. In case of compressive, again, there may be extramedullary and intramedullary, but it's very difficult to differentiate clinically whether it is extramedullary or intramedullary. But there's some few minor point. It's like root pain is very early in case of extramedullary, and it's poorly localized in case of intramedullary. There's no dissociative sensory loss in case of extramedullary. Dissociative sensory loss is intramedullary. Dissociative sensory loss means whenever we are in the sensory system, we are having two pathways basically. One is pyramidal spinothalamic tract, one is posterior column. And sometimes it may happen that there is involvement of the one tract with sparing of the other tracts. Like patient may have involvement of the spinothalamic tract, but patient may not have involvement of the posterior column sensation. That is known as dissociative sensory loss. And sacral sparing is present in case of intramedullary, and it's absent in extramedullary. Now, coming to the individual cause, that first cause of central cause of spastic paraplegia is thrombosis of unpaired anterior cerebral artery. Now, how this anterior cerebral artery infarction can cause weakness of the both lower limb. Normally, as we know that stroke normally causes hemiplegia, but that hemiplegia is normally caused by involvement of the middle cerebral artery. If there is a right-sided middle cerebral artery involvement, the person will have left-sided hemiplegia. But isolated anterior cerebral artery normally supplies motor leg area of the frontal cortex. So right frontal cortex will supply the left-sided leg area. So if there is suppose thrombosis of right anterior cerebral artery, then definitely there will be weakness or paralysis of the left lower limb. Now, as we know that circle of Will is having so many anomalies. There is one common anomaly is both the anterior cerebral artery arises from one common stem. And if suppose patient is having both the anterior cerebral artery arising from one common stem, That means that one common stem is supplying both the lower limb. And if patient is having thrombosis of that unpaired anterior cerebral artery, then patient will have paraplegia. So that only suppose if you don't write the unpaired term, then it will not cause paraplegia. If patient is having anterior cerebral artery in two anterior cerebral artery, right and left, and if there is infarction of either right or left anterior cerebral artery, then patient will have weakness of the opposite lower limb. But if patient is having thrombosis of the both anterior cerebral artery, which is very unlikely if patient is having two arteries, but there is a, if suppose both the arteries arises from one common stem, there is a possibility that patient may have thrombosis of the unpaired anterior cerebral artery that may causes paraplegia. So when you suspect if there is paraplegia along with paraplegia, when you suspect anterior cerebral artery involvement, if there is urinary incontinence, again that urinary involvement may be there in spinal cord also, but if there is ebulia or akinetic mutism, patient is mute with paraplegia and there is Graves reflex, sucking reflex, impairment of gait and stance, all those things are there, then always you have to suspect anterior cerebral artery. That's why it is very important whenever you take a history from paraplegia, then normally we do think that this is always due to spinal cord lesion, but sometimes you have to ask about the history of cognition, history of seizure, history of altered sensorium to rule out the central causes. Okay, so the thrombosis of unpaired anterior cerebral artery is one of the important cause of central cause of paraplegia, and when you have to you should have suspicion if there is associated some cognitive impairment, patient is mute, urinary incontinence, or some Graves reflexes are present, then you have to suspect for anterior cerebral artery involvement. Then second one is superior sagittal sinus thrombosis. Superior sagittal sinus thrombosis is basically the vein system. So cerebral vein drainage, if you look for the anatomy, there are two systems. One is superficial venous system, one is deep venous systems. And the drain blood runs into the major usual sinuses. One is superior sagittal sinus, inferior sagittal sinus, lateral sinus, cavernous sinus, and straight sinus. Ultimately, they drain to internal jugular vein. So cerebral venous sinus thrombosis is one of the important complications, especially in pregnant lady, in patient is having hypercoagulable state, and a patient is dehydrated. Then, especially in female patients, then you should have suspicion for thrombosis of the superior sagittal sinus, especially if patient is presented with continuous severe headache, sometimes with seizure or convulsions, with visual defect, altered mental status, and along with sometimes patient may have weakness of lower limb, sometimes in the upper limb, then you should have suspicion for cortical venous thrombosis. Diagnosis is by MRI brain. And why it is important to diagnose superior sagittal sinus thrombosis? Because here heparin is the drug. So you can save the life with the heparin only. And this is the only indications where even there is normally heparin we do not give if patient is having intracerebral bleed. But in patient with superior sagittal sinus thrombosis or cortical vein thrombosis, if they are having slight bleeding inside the brain also, then also you have to give heparin to prevent the complications from the superior sagittal sinus thrombosis. So again, it is one of the important central cause of paraplegia. Again, when to suspect if patient is paraplegic, especially female patients, maybe in the puerperium state or during pregnancy state, and if she is having some hypercoagulable state disorders and complaining of headache and a non-specific seizure, some visual defects, then always you should go for MRI brain to rule out cortical vein thrombosis or superior sagittal sinus thrombosis. Central Pontine myelinolysis. This is one of the important entity, which is normally it's basically a medical. What you can label it as medical, sometimes negligences. What happens in suppose patient presented with severe hyponatremia, like normal sodium level is 135 to 145, and less than 130 of sodium normally causes altered sensorium. If patients presented with severe hyponatremia of sodium 110 or maybe 100, and and you know that the normal level is 135, and if you correct of 25 sodium within 24 hours, then there may be chance of central pontine myelinolysis. Patient will not die of hyponatremia, but patient may die because of central pontine myelinolysis, which may occur due to rapid correction of sodium. So it is very important to remember whenever patient presented with even sometimes patient may present with coma also, and if sodium is very low, then always you have to correct gradually, not within 24 hours. Like patient is having 110 sodium, then by next 24 hours you can expect around 120, not more than 120. The next day you can expect up to maybe 125, 126. Then gradually correct that over 3 to 4 days, patient will have 135 to 140. So enthusiastically, if you correct almost 30-40 milliequivalent of sodium within 24 hours, then you may end up with central pontine myelinolysis. So usually patient present with quadriplegia and pseudovalvular palsy, sometimes may present with confusion, dysarthria, and disturbance in conjugate case. Mostly they are patient already having underlying medical illness like diabetes, cancer patients, and having nutritional deficiency. So there is demyelination, pseudo-inflammation at the base of the pons with relative sparing of the axons and nerve cells. Therapeutic guidelines for correction of hyponatremia is less than 10 milliequivalent per liter within 24 hours or 20 within 48 hours. So roughly patient is having 110 of sodium, then over next 24 hours you can correct up to 120 less than, and next 42 hours you can correct up to 130. So to bring it to the normal level, you should take minimum 72 to 96 hours. These are a few important acute cause of paraplegia, spastic paraplegia. Now the chronic paraplegia, one is cerebral dysplasia, also known as spastic paraplegia. It was historically known as little disease. It's a form of cerebral palsy that is a chronic neuromuscular disease of hypertonia and spasticity, manifests as an especially high and constant tightness or stiffness in the muscles of the lower extremities of the human body, usually those of legs, hips, and pelvis. It's one of the type of, I think in the pediatric neurology, you have come across with the cerebral palsy. It is one of the most important cause of cerebral palsy. So in case of infant or maybe in the children, if patient shall present with paraplegia or diplegia, then you should think of this hereditary disease. Parasitic meningoma is one of the tumor of the brain that fills the parasagittal sinus, basically area of involvement is the parasagittal sinus in the tumor. So it's basically slow growing tumor. Patient may have focal seizures, headache, and paraplegia. So again, that's why in any patient with paraplegia, if patient is having some central nervous system symptoms like headache, seizures, visual defects, then always first you advise for one imaging of the brain, and by imaging you can rule out any of these conditions, maybe anterospinal artery thrombosis, cortical vein thrombosis, or maybe parasitic meningoma, central pontine myelinolysis. So all of these conditions you can rule out by MRI brain. So it is important to take the history of central nervous system even when patient presented with paraplegia, especially to rule out all those central causes of paraplegia. Coming to the spinal causes of paraplegia, one of the important cause why I put in the number one is spinal epidural abscess or spinal subdural abscess. Why it is important? Because this is only surgical conditions we can may present with paraplegia, and it's just simply giving antibiotics sometimes or sometimes simply doing drainage. You can save the lymph. Plegic lymph. So usually patient presented with back pain, with fever, and limb weakness. So with paraplegia, if patient is having fever and there is tenderness or back pain, then always suspect subdural abscess, especially if patient is having altered immune status, like patient is immunocompromised with chronic kidney disease patient is on steroid, IV drug abusers patients, and patient is having localized infections, then you should have suspicion for subdural abscess. Most common there may be gram positive or gram negative, like Staph aureus is one of the important cause of subdural abscess. Sometimes gram negative bacilli, especially if there is septicemia, sometimes streptococci, and in our setup, there is chronic history of pain and fever, then always you have to rule out TB or Pott's disease. Diagnosis, you have to ask specifically for MRI spinal cord, and if there is, you have to find out the exact tenderness, whether it is in the thoracic regions or lumbar regions. Then accordingly you can ask for the MRI spinal cord of specific level. And why it is important? Because you can go for long-term antibiotic therapy, and immediately you have to go for the decompressive laminectomy with debridement. Spinal epidural or subdural hematoma, it's hemorrhage into the subdural space. Usually patient presented with like same feature like subdural abscess. There will be a good focal or radicular pain, probably variable sign of spinal cord diseases. This may happen during therapeutic anticoagulation, like you are giving heparin or oral anticoagulant like acetrom and warfarin for some other reasons, and patient may develop bleeding in the epidural space. Sometimes maybe because of trauma, sometimes because of tumor, any blood dyscrasia like hemophilia, Christmas disease, ITP, they can cause bleeding into the subdural space. And sometimes, although unfortunate, sometimes can happen during lumbar punctures or epidural anesthesia. Again, diagnosis by MRI of the spinal cord. Treatment, if there is primary cause, then you have to treat the primary cause, like patient is having idiopathic thrombocytopenic purpura, you have to treat the ITP. Patient is having hemophilia, you have to treat the hemophilia. And if there is not, then if there is trauma or some other reasons, then you have to go for surgical decompressions. Hematomegalia is basically hemorrhage into the substance of the spinal cord. Like in the epidural hemorrhage is the subdural hemorrhage is there in the space, but here in the substance of the spinal cord. Again, the cause may be trauma, intraparenchymal vascular malformations, sometimes vasculitis due to polyartery embosa, or SLE, bleeding disorder, or spinal cord neoplasms. Again, presentation may be acute painful temperasumeritis, diagnosis by MRI, and mostly the supportive treatment here. If there is some vascular malformation, then you can go for angiography and evaluate and remove the underlying vascular lesion. These are not very common, rare causes. Pott's spine, one of the important causes, especially in countries like India, where tuberculosis is very common. So spinal TB, also known as Pott's disease or tuberculous spondylitis, often involves two or more adjacent vertebral bodies. That's how you have to differentiate it from the neoplasm or some other causes. The most common site of involvement of tuberculosis is the thoracic spine. Is the most common site. Upper thoracic in case of children and lower thoracic in case of adult. So overall, the thoracic vertebra is the most common spinal cord involved in case of tuberculosis. With advanced disease, there may be collapse of the vertebra resulting in kyphosis. It is also known as give bust. That's why it is very important to palpate the spine to find out any give bust. And sometimes there may be formation of cold abscess, which may be in case of sometimes may penetrate the chest wall, and sometimes it may penetrate towards the abdomen or inguinal ligament and may present as Schwarz abscess. And then CT or MRI helps to differentiate. There are some special characteristics features of tuberculosis spine. And it is important because once you level it as Pott's spine, then you have to give ATT. And with ATT, most of the patients, they improve. If they don't, then you have to go for the, again, decompressive surgery. Neoplastic spinal cord compressions. Spinal cord tumor is not very common, but anyway, in case of chronic compressive myelopathy, you have to rule out tumor. Tumor, there may be two types. One, it may be intradural or extradural. And extradural is outside the dura. It's mostly due to metastatic, and intradural, it may be extramedullary or it may be intramedullary. Extramedullary intradural tumor, they're located inside the thin covering of the spinatus dura, but outside the actual spinal cord. The most common type of extramedullary tumor are meningioma, neurofibroma, and ependymoma. Intramedullary tumor, these are less common. It's inside the spinal cord. Astrocytoma and ependymoma are the two most common types of intramedullary intradural tumor. As I have said, extradural tumor, they are mostly of metastatic. The common primary cancer that spread to spine is lung, breast, and prostate. lung cancer is the most common carcinoma, metastasis to bone in men, and breast carcinoma is most common in women. And thoracic spinal column is most commonly involved. There are some exceptions. In case of metastasis from prostate and ovarian, in case of prostate, it mostly metastasis to the sacrum. In case of ovarian, it's mostly metastasis to the lumbar vertebra. Otherwise, overall, the metastatic cancers, they are most commonly involved the thoracic vertebra. Spondylitic myelopathy, normally spondylosis is not very uncommon, but myelopathy is not very common, but still, again, it can have both acute as well as chronic presentations. And mostly it involves the cervical cord, but sometimes it may involve the lumbar. Thoracic involvement is very uncommon as a spondylic. Prolapse this is common either in the C5, C6 distributions, or in case of lumbar it is L4, L5 distributions. In case of cervical, patient will have neck and shoulders pain with mostly they are of radiating pain. It started over the back of the neck, radiates towards the fingers. And in case of lumbar pain, it will start over the low back regions and it will radiate towards the both sides of the legs. And you may get sometimes paresthesia, and there may be involvement of the sensory loss. In case of cervical lesions, there may be sometimes atrophy of the intrinsic muscles of the hand. Then there will be increased deep tendon reflexes of the legs, extensor plantar expanse. Again, diagnosis by either MRI and sometimes maybe CT. Treatment is first you have to go for the collar, and if there is weakness or focal deficits is there, then you have to go for surgery. In case of early, only suppose patient is complaining of only pain or paresthesia, then you can go for conservative management. But if patient already develop weakness and if there is focal deficits, focal neurological deficit means if there is power is less, if you are getting extensor plantar, and there is some atrophy of the muscles, there may be hypertonia of the muscles, these are called focal deficits. If focal deficits there, then you have to go for surgical decompressions. Now the important cause of inflammatory myelopathy, these are called non-compressive myelopathy. Whatever we have discussed, these are all causes of compressive myelopathy. Now we'll come to the non-compressive myelopathy. The most common cause of non-compressive myelopathies are basically demyelinating lesions. Amongst the demyelinating lesions, are having three important causes. One is multiple sclerosis, second one is neuromyelitis optica, and third one is idiopathic acute transverse myelitis. And sometimes it may be due to some infection per se. Infection, mostly herpes zoster, herpes simplex type 2, Epstein-Barr virus, cytomegalovirus, rabies, some bacteria like Listeria, Borrelia, Toxoplasma, Syphilis, they all can cause inflammatory myelopathies. And it may be sometimes immune-mediated, like in patient with systemic lupus erythematosus, Sjogren's syndrome, Behçet disease, and sarcoidosis. So, acute non-compressive myelopathy mostly we get due to idiopathic transverse myelitis, maybe sometimes relapse case of multiple sclerosis, sometimes maybe there is involvement of weakness as well as optic neuromyelitis optica. And then definitely you have to rule out all the infections if possible, and sometimes some autoimmune diseases. Multiple sclerosis is one of the important demyelinating disease. Is mostly present in female, and there is usually history of relapse and recurrence. The first episode of multiple sclerosis is very difficult to differentiate from acute transverse myelitis. Presentation is almost same like as acute transverse myelitis, except there will be relapse and recurrence in case of multiple sclerosis. So in multiple sclerosis, lesions are usually small, less than 2 vertebral segments, and peripheral, and it causes mostly asymmetric symptoms and signs. Lermite sign, that is paresthesia spreading down to the spine, often into the legs or neck movement, is typical for demyelinating lesions of the cervical posterior column. And other characteristic symptoms are isolated proprioceptive loss of upper extremities, Brown-Sequard syndrome, and if you do the CSF analysis, will get oligoclonal bands, and sometimes you get some indexing you have to do, and definitely by MRI brain or spinal cord you can have specific lessons for demyelinating disease. Neuromyelitis optica is it's a relapsing demyelinating disease where there is involvement of optic nerve as well as spinal cord. This is just part of multiple sclerosis, but the diagnosis is different. You have to ask for the equivalent or antibodies, which is present in case of neuromyelitis optica. Spinal cord infarction, this is one of the important cause of paraplegia. As you know, the spinal cord is supplied by three arteries. One is one single anterior spinal arteries and paired posterior cerebral artery. So if there is acute infarction of the anterior cerebral artery, it produces paraplegia or quadriplegia, dissociative sensory loss affecting pain and temperature sense but sparing the vibration and position sense, and loss of sphincter control, also known as anterior cord syndrome. Infarction of posterior cerebral artery not very common. It results in the posterior column functions, and causes are many, mostly of aortic atherosclerosis, dissecting aortic aneurysms, vertebral artery occlusions, aortic surgery, and sometimes in severe hypotension following any cardiac surgery. So if there is involvement of thrombosis of anterior cerebral artery or 2 PSA, then it may cause hemiplegia, and based on the involvement you may have either spinothalamic tract sensory systems or posterior column sensory loss. Syringomyelia is nothing but the formation or development of cavity in the spinal cord. It may be acquired or may be hereditary. Acquired hereditary cause mostly associated with Chiari type 1 malformations. Acquired Syrinx may be due to trauma, myelitis, then tumor, or sometimes arachnoiditis. Its presentation is central cord syndrome, consisting of dissociative sensory loss, that is loss of pain and temperature sensation with sparing of touch and vibrations. That means loss of spinothalamic tract and sparing of the posterior column with areflexic weakness of the upper limb. The sensory depth distribution, also known as cap distributions, and sometimes there may be extension of the syrinx into the medulla. It can cause syringobulbia, causing palatal or vocal cord paralysis. And MRI spine would help the diagnosis of syrinx, and treatment is surgery. Again, it is the chronic cause of noncompressive myelopathy. Subacute combined degenerations, it occurs due to vitamin B12 deficiency, and it's one of the treatable cause of myelopathy. That by name only it can make out. Subacute means it's a not chronic also and not very acute also, in between weeks durations. Combined means there is involvement of both posterior column as well as pyramidal tract. Patient will have weakness along with loss of vibration and position sense. That's also combined. And degeneration means degeneration of the posterior column or the spinal cord. So patient will have loss of reflexes associated with peripheral neuropathy in a patient who is having Babinski sign due to pyramidal tract lesions. Patient may have optic atrophy, and diagnosis is confirmed by the low vitamin B12, and this condition is completely reversible if you give supplement or if you give or supplement with vitamin B12. Acute idiopathic tremorous myelitis is it should come in the with the previous slide. It's an inflammatory tremorous myelitis. Basically, it's a diagnosis of exclusions. Once you rule out other causes of myelitis, then especially multiple sclerosis or other infection causes, then you label it as acute idiopathic tremorous myelitis. Why it is important? Again, because one is treatment protocol is totally different. If you level the patient as acute idiopathic tremorous myelitis, you have to give pulse steroid, maybe methylprednisolone 1 gram OD for 3 days, followed by oral steroid. So, and if it is infective and other causes, then you have to treat the primary cause. Now coming to some rare cause like primary lateral sclerosis. It's a rare upper motor neuron variant of motor neuron disease. As you know, in motor neuron disease there is involvement of both upper motor as well as lower motor neuron disease. And if there is only involvement, of both, that is known as amyotrophic lateral sclerosis. If there is involvement of the only upper motor neuron lesions, this is called primary lateral sclerosis. And if it is only lower motor neuron lesions, it is known as spinal muscular atrophy or SMA. So PLS is mostly present in the age of around early 50s, and there is slowly progressive spastic paraplegia of the lower limb. And in case of motor neuron disease, 3 things you have to note that there is no sensory bladder, no sensory loss, bladder ball involvement is very unusual, and cognition is normally grossly normal. So 3 things remain intact in case of motor neuron disease. One is sensory, one is sphincter involvement, and third one is brain involvement or cognition involvement of the cognition or memory. They remain intact. Diagnosis by exclusion, and there is no specific treatment. Trapezius dorsalis nowadays is very rare to get. It was classically described with the syphilis, and the normal. If you go for the natural, if you look at the natural history of the syphilis in the after secondary syphilis, in the tertiary syphilis, there may be neurological involvement. In the initial stage, there may be trapezius dorsalis involvement of the mostly the anterior horn cells. Person will have fleeting or repetitive lancinating pain, primarily in the legs, and less often in the back, thorax, abdomen, arms, and faces. There may be paresthesia, bladder disturbance, and sometimes there may be acute abdominal pain. So there is involvement of the posterior column with loss of position and vibration sense, rhombox channel positive. And what we will get specific for syphilis is bilateral argyle Robertson pupil, which fails to constrict to light but to accommodate. They are reflecting to the accommodate but not to light. This is bilateral argyle Robertson pupil is very classical of syphilis or trapezius dorsalis. Sometimes the patient may present with paraparesis. Tropical spastic paraplegia, it's again very rare to get, mostly found with retrovirus, that is human T-cell lymphocytic virus HTLV1. It mostly involves the thoracic cord. Again, it's very slowly progressive. Spastic syndrome mostly present around 30 years of age, and there may be painful sensory neuropathy, bladder ball involvement. We'll get upper motor neuron sign in the lower extremities, weakness, spasticity, and hyperreflexia, and diagnosis by the demonstration of virus HTLV1 by ELISA test. No specific treatment. You have to treat the conservatively for spasticity and bladder symptoms. Hereditary spastic paraplegia, again very rare to get genetically, and it's mostly autosomal dominant, sometimes X-linked recessive, second to third decade, may be associated with deafness, neuropathy, hemolytic anemia, optic atrophy, and mental retardation. That's why family history is very important in case of paraplegia, especially if you are not getting any clue for a diagnosis, then sometimes in a genetic disease you have to take in considerations. Laterism sometimes is a toxic nutrient for theoretical discussion. Chronic toxic nutritional is a neurological disease caused by long-term ingestion of flour made from sickling pea, that is Lateris sativus. Responsible to neurotoxin is beta and oxyl amino L-alanine BOAA. And ingestion of this neurotoxin results in increased intracellular level of reactive oxygen species and subsequent impairment of the mitochondrial oxidative phosphorylation chains. Patient usually present with muscle spasm, cramp, and leg weakness. In addition, there may be sensory and bladder dysfunction. Friedreich ataxia, again one hereditary disease, mostly important for MCQ. Lots of MCQs are there from this topic. It's common in before 25 years of age with progressive staggering gait, frequent fall and titubations, nystagmus, loss of saccadic movements, truncal titubation, dysarthria, dysmetria, ataxia. Will get extensor plantar but absent reflexes, loss of posterior column, and genetic link is to the long arm of 9 chromosome, and there is triplet repetition with GAA. What is more important is cardiac involvement, occurs in 90% of cases, and high incidence of diabetes mellitus is found with insulin resistance and pancreatic beta cell dysfunction. So this is one of the rare disease, but again, lots of MCQs are there from this topic. So at least you should know for theoretical discussion. It's one of the important cause of weakness with extensor plantar and absent reflexes. Normally in extensor plantar we are expecting hyperreflexia, but in this condition there will be loss of reflexes because of involvement of the peripheral nerve. So on evaluation or the testing for the paraplegia, you have to definitely ask for the MRI of the spinal cord with or without the contrast. Then in some conditions, you have to ask for the CSF studies. You have to look for the cell count, protein, glucose. In multiple sclerosis, you have to look for IgG index, then oligoclonal band, PDRL, Syphilis, gram stain, acid fast bacilli for tuberculosis, Indian ink stain for fungal, PCR for varicella zoster, herpes simplex, Epstein-Barr, cytomegalo, human herpes virus 6, enterovirus, HIV, antibodies to HTLV1 to rule out tropical spastic paraplegia, Lyme disease to rule out by Borrelia burgdorferi, viral, bacterial, mycobacterial, fungal cultures. It's not that every patient you should ask for everything, but you have to individualize the patients. Blood culture, then serology for HIV, PDRL, then for to rule out immune-mediated disorder, you have to ask for ANA, then dsDNA, RA factor, then Sjogren syndrome, you have to ask for SSA, SSB, complement level, APLAS, ANCA, thyroid, all these things you have to do. For sarcoidosis, you have to ask for S inhibitor, S enzyme, serum calcium, X-ray, SCT, lymph node biopsy. For demyelinating disease, you have to go for MRI brain, then evok potentials, then CSF oligogonal blend, and then sometimes anti-aquaporin for antibodies. Then to rule out vascular cause, you have to look for the CTA myelogram and spinal angiogram and others like vitamin D, B12, SAS for specific conditions. Treatment, you have to treat the primary cause, like in case of acute temperasumeritis, you have to give pulse methylprednisolone followed by tapering dose of steroid. In case of subacute combined degenerations, you have to give vitamin B12. In case of subdural abscess, you have to give proper antibiotic. Then others are symptomatic treatment, like for bladder dysfunction, you can give long-term catheterizations, anticholinergic drugs. Then heparin prophylactically for a patient is bedridden for a long time to prevent DVT. Prophylaxis against decubitus ulcer, then baclofen for spasticity, for chronic pain, gabapentin, pregabalin, etc. So this is all about for paraplegia, how to go, how to find out the causes and management of paraplegia. If you in examination, if you ask to write about acute paraplegia, then you have to write acute. Sometimes they may ask specifically for compressive or non-compressives. If they ask only for paraplegia, then first you have to divide it as a spastic and flaccid. Mostly they used to ask for either spastic or flaccid. In case of spastic, you have to write the cerebral and spinal cause. Cerebral cause, you have to mention all the cerebral causes. In the spinal causes, you have to mention about the compressive and non-compressive. If you cannot remember about the acute and chronic causes, at least you should remember about the in spastic causes, in central cause, at least you should remember about 3-4 central causes of paraplegia. In spinal causes, at least you should know some compressive and some non-compressive causes, and at least you should know how to differentiate compressive versus non-compressive. In case of lower motor flaccid paraplegia, basically all the lower motor neuron disease will come, starting from anterior horn cell disease to neuropathy to manual junctions or myelopathies. So most important is the spastic one, because you have to differentiate it from compressive as well as versus non-compressive lesions. Okay, so this is all about the paraplegia. Thank you.